She is the Director of Research and Community Analytics within the Department of Medical Informatics. Her background, she has her PhD in epidemiology from the University of Oklahoma. She received her MPH from St. Louis University with a concentration in epidemiology and biostatistics. And she is an informatician of the first order. Much of her PhD work and then moving on to practice, much of her work was involved with the use of electronic records, data science, big data, and understanding the validity of, as we extract data for use in quality improvement and business operations for our organization, as well as for the state of Oklahoma. So I think today is going to be incredibly interesting because she's going to be presenting on some of the transformative work that she's doing that is not only improving our understanding of how we deliver healthcare services, but also what we're doing to try to transform care in Oklahoma and to try to raise the quality of mental health care delivery throughout the state, even amongst rural, impoverished, vulnerable populations. So please help me welcome Dr. Juell Homco.
And so I don't have any personal disclosures, but I would mention that a lot of the work I'm talking about is funded by the Department of Mental Health. And so this presentation does not necessarily represent the official views of the Department of Mental Health. So what I'm hoping to cover is describing the use of dissemination and implementation science to accelerate the implementation of evidence-based guidelines in primary care. It's a mouthful, and we're going to talk, you'll understand what that means a little more here in a little bit. Also, specifically talk about some of the best practices related to implementing SBIRT in primary care, and then really dive into some of the complexity and some of the lessons learned to date on what it takes to implement universal screening in primary care. First, I have a couple slides on the state of health in Oklahoma. Many of you have seen similar slides to this, where we consistently see Oklahoma ranking near the bottom of every major health indicator. This is one of the most recent reports I could find from the Commonwealth Fund. It's the 2022 scorecard on state health system performance. And unfortunately, it still shows overall Oklahoma is ranking 50 out of 51 overall. And then you can see there are several other metrics related to, how we've handled COVID-19, access and affordability, et cetera. And so we rank anywhere from 42 to 50 on each of those indicators. But I wanted to dive in specifically and talk about a couple of metrics related to mental health. So I have a QR code here if you're interested. This will get you to a very dynamic Tableau dashboard that's provided at the state health department's website. They put out the state of the state's health report. And so I wanted to give you access to this report because you could, what I'm going to show next is available using this QR code, and you can kind of slice and dice beyond what I'm going to show you if you're interested. So this first dashboard, just to sort of orient you here, is showing you this measure related to number or percentage of adults that report having depression ever. And so the dashboard on the State of the State Health Report shows Oklahoma and how we compare to other states across the country. And then on the right side here, there is a number of different demographic variables where you can kind of slice and dice this measure by maybe age group, race, gender, et cetera. So that's where if you use a QR code, you can kind of explore everything that's out there. And then every state is given, they've sort of normalized the data and then given Oklahoma and every state in the country a grade, A, B, C, D, or F, similar to elementary school. And so you can see here on this depression measure, we do get a grade of D. Similar, this is poor mental health days. So this is the percentage of adults that report having poor mental health at least 14 out of the last 30 days. And so Oklahoma, you can see here, also ranks really low compared to the country. We do have a grade of F in this area. But on the side here, just to give an example, you can see that this very much differs by education level reported by adults in Oklahoma. I also pulled smoking prevalence. I'm always interested in this. When I moved to Oklahoma, I was shocked by how many people smoke here because I was like, we don't even grow tobacco. I'm not from here. But we do still, the data still shows roughly 20% of adults reporting being current smokers in Oklahoma. And so we do get a grade of D here. And then suicide deaths, this is based on number of suicide deaths per 100,000 population. It is age adjusted. And so we have a grade D here. You'll see this also very much differs by race, ethnicity, and actually gender. I couldn't fit it all on one screen, but you see that, you know, the highest rates here are among males and whites. So I don't know if that's shocking to everybody, but there is definitely a lot of discrepancies here in this data. And this is a stat. There's been some research done. This really stands out to me when we think about how are we going to address some of these mental health concerns in our state and in our country. There's been research that indicates that 45% of those dying by suicide saw their primary care physician in the month before their death. And I think that is really powerful because it shows this is such a great opportunity for intervention, right? And to identify and intervene for these individuals. I also did a quick Google search, and this is not surprising. So the data I showed is a few years old. It's the most recent data that's available on the State of the State's health report. But we all know that these issues have been exacerbated by the COVID-19 pandemic. And so I did a quick Google search, and it was not hard to find lots of different titles out there just highlighting how COVID-19 has impacted mental health in this country. And I mentioned that we need, you know, one area to intervene for this is in primary care. And so I also pulled this title. Many of you have probably heard this or are aware that at the same time, primary care physicians in general, they're feeling a whole new level of burnout that we haven't seen before after the pandemic. So I've mentioned this, one solution to improve or to identify and address mental health is better integrating behavioral health and primary care. And so one potential solution is SBIRT. How many of you have heard of SBIRT? Okay, that's great. It's like maybe half the room. So SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And so this quote here is from the SAMHSA website. And it really says, you know, SBIRT is a comprehensive, integrated public health approach to delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk for developing these disorders. And so the key words here is it's comprehensive, it's integrated, and it is this overarching public health approach to tackling these. And so when we talk about annual screening, this includes comprehensive screening. And so, for example, screening for alcohol use and misuse, so that's using the audit screening tool. DAS-10, which is a screening tool to screen for drug use or misuse. Screening for tobacco use. Screening for depression using, for example, the PHQ-9. And then screening for suicide severity risk, using something like the Columbia Suicide Severity Rating Scale. And this just highlights there is evidence supporting these screenings. So this is sort of a grid looking at each of those different screenings. So alcohol, drug use, tobacco use, depression, suicide, and then the evidence for screening, providing brief intervention, and referral to treatment. And so there is evidence supporting the use of most of these. You'll notice the two kind of bluish gray boxes show that there really just hasn't, these have not been well studied. But there's been a lot of studies really showing that screening reduces lifetime costs. And I don't think that surprises anyone, but really there's evidence supporting implementing SBIRT really does improve lives by providing early treatment of depression, for example. It saves lives by preventing suicide and treating addiction. It results in reduced frequency and severity of substance use, reduced morbidity and mortality of chronic conditions, and it leads to decreased healthcare costs and utilization. All not surprising, right? So the question is, when I say we need to implement SBIRT into primary care, how do we, it sounds simple, right? We just need to do this. But those of you who work in primary care know that it's not that simple to implement things like this, right? And so I think in order to sort of talk through that, I'm going to quickly describe what OPHIC is, which is the Oklahoma Primary Healthcare Improvement Cooperative, and hopefully tie this all together. So OPHIC really is centered in the NIH-funded OCTSI, which is the Oklahoma Clinical and Translational Science Institute, which is housed in Oklahoma City at the Health Sciences Center. So this really is a Health Sciences Center consortium, and it really is a collaboration. Like I said, I'm not running OPHIC by myself, right? There's a lot of us, but it really is a collaboration across departments on both the Oklahoma City campus and the Tulsa campus. So for example, we have experts from the Department of Family and Preventive Medicine in Oklahoma City. We have folks from the College of Public Health and the Department of Medical Informatics. And so this infrastructure, this formalized infrastructure to do all the work we're doing through OPHIC really was developed through our ARC, Evidence Now, Healthy Hearts for Oklahoma study that we received back in 2014. That was a $15 million grant from the Agency for Healthcare Research and Quality that really helped us formalize this infrastructure. And so this group, we really are experts in quality improvement techniques and techniques to disseminate and implement the emerging evidence-based guidelines. And we do not do this in a silo, right? This relies on a lot of different partnerships. And so when I say we really work on helping primary care practices specifically implement evidence-based guidelines, why is that so important and what does that mean? Some of you may know, and some may not, but when it comes to guidelines, they're constantly changing, right? And I have just this one example to walk through that hopefully illustrates how complex this is for providers to stay on top of all of the ever-changing guidelines and evidence. So this is just one example. In 2016, the CDC released this guidelines for prescribing opioids for chronic pain. It was a 52-page document. And then fast forward in 2017, the VA and DOD, they released this clinical clinical practice guideline for opioid therapy for chronic pain, and it was 198 pages. And then around the same time, we also had new state laws and legislation that was really dictating what can and cannot be prescribed in the state. And so the question is, how are providers staying up to date with all of these guidelines? Right? I mean, this is just one topic. You can imagine the guidelines. We've had guideline changes when it comes to cholesterol management, blood pressure control. Like the list is very, very long, and it's really hard to stay on top of all of this evidence. And so that is what we are really trying to help primary care with. And just another way of looking at this. So you guys, I mentioned that the guidelines are constantly changing, right? We have randomized control trials. We learn new things, that gets updated. What we learn gets updated in the guidelines. And then our goal is to implement those guidelines in primary care. How long do you think it takes for results from randomized control trials to make it into primary care on average? Some of you have probably already heard me say this, but any guesses?
10 years.
10 years? Research shows that on average, it takes 17 years for results of randomized controlled trials to make it into primary care. So that is exactly why what we're doing is so important. So we're really focusing, how do we speed up the adoption of evidence-based guidelines? And then so what we're doing too from a research standpoint is let's evaluate how we're doing this and what works well so that we can do this more broad scale. Does that make sense? When we think about, and maybe this is hard to imagine being at an academic center, we're much closer to the evidence, right? We have access to the latest journals. We maybe are hearing this information. You also have, primary care, we also have these Rule 1 doctor providers who, how are they getting all of these updates, right? I mean, everybody is battling this. So what we have developed, we have developed this intervention sort of QI bundle of support that we provide in all of our OPHIC projects. So in order to speed up the adoption of evidence-based guidelines and help these practices. So we always provide these 5 things: academic detailing, practice facilitation, technology support, performance feedback, and then other support depending on the project. We currently have several projects going on with OPHIC, all focused on this D&I dissemination and implementation research, helping practices implement evidence-based guidelines. But what I'm going to dive into is specifically our SBIRT projects. And then also to say again that we do not do this alone. It takes a lot of partnerships, both state government agencies, we have technical partners, and we have community partners that help make all of this work happen, because we are really doing this across the entire state. So how is OPHIC implementing SBIRT? So specifically, we have 3 SBIRT studies that are currently active. So we have our SBIRT, that top one we call SBIRT OK, so SBIRT Oklahoma, and it really is focused on primary care practices that are serving adult populations. And we have to date, we have worked with a total of 47 practices across the state on our SBIRT OK study. And then we have SBIRT A-OK. You can imagine we've had to tailor some things. This is focused on targeting practices that serve adolescent patients. And so, you know, some of those screenings that I talked about, you have to tailor for adolescents. There's little nuances that we have to tailor for that. And then our HAU, or our SBIRT HAU, we are partnering with the Health Alliance for the Uninsured. And so this is focusing on primary care practices that serve patients without insurance. And we currently have 7 practices that are working with us on that. So how are we, this is another sort of graphical way to kind of show how is OPHIC implementing SBIRT. And so I mentioned before, SBIRT stands for screening, screening, brief intervention, and referral to treatment. And so obviously to implement SBIRT, we have to implement universal annual screening. We have to implement workflows to help support brief intervention. And then same with referrals to treatment. And then we added OK because we thought it was really important to highlight that we have to tailor everything we're doing to match what will work in the state of Oklahoma. And so this is just a map showing our SBIRT OK practices that we have worked with across the state, just to show that they truly are geographically dispersed across the state. So I keep saying we're implementing SBIRT. What does that mean? Right? And so I'm going to go through a couple of slides that sort of highlight what our goals are for SBIRT implementation in these practices. So the first one, and this is, you know, must be done, right? So for implementing SBIRT, you must implement screening. That's step 1 for SBIRT, right? And so, which sounds simple, but it's more complex than that. But the goal of our SBIRT programs are to conduct annual screening for every patient seen in a primary care practice. And again, we are specifically want to screen for depression, alcohol, drugs, tobacco, and suicide risk. There are there's a couple different options for how that screening is offered. That's something that can be done away from the office, maybe within 24 hours of an in-person visit, maybe through like a patient portal, or it could be done in person immediately before an appointment on a tablet, for example. So again, we've added flexibility. It's helping these practices implement workflows that allow SBIRT to happen. We were lucky, I mentioned that we've partnered with the Department of Mental Health. They actually built an online screening tool. And so this has been something that we have offered to these practices. And so we actually have purchased tablets. We have lots of tablets running around, all through appropriate IT review. And we have used these to help model with a practice on, you know, how you can implement SBIRT using the tablet and using this online screening tool the Department of Mental Health has provided. And then we also provide money to the practices to help them pay for their own tablets so that they can purchase their own tablets to implement this long-term in their practice. This is an example of some of the screening tool functionality. It's sort of tiny here, but what I wanted to highlight is, and maybe I have it highlighted here. No, I don't. You can sort of look at your dashboard in the screening tool, and there are flags for when a patient has indicated suicide risk. And so it's also in the practice identifying workflows so that someone is catching this and reacting to this in the practice, right? Which is similar to this. So that's the other goal, is making sure that the practice is trained and they feel confident responding to a patient that does present with suicide risk. And so that includes making sure the appropriate people are notified, administering that Columbia, the CSSRS evaluation, and then establishing a suicide prevention plan with the patient there in the practice. And this is just an example of what that CSSRS looks like. And then also, I mentioned that we do a lot of work. We also have a zero suicide program where we're training the practices to really make sure this is comprehensive training in the practice around suicide prevention. Another big goal of this work, because again, at first you thought, oh, this is easy, just implement it in the practice, right? But there's all these little nuances. The question is, so they're using the screening tool that has been provided by the Department of Mental Health, but that is separate from their EHR. So there's also a lot of work going on determining how do we get the information from the screening tool into the EHR, what needs to be documented, how is this documented, making sure that it's happening. Okay, and then I'm going to dive into, so how are we making all of this happen? And dive into, I mentioned these are the 5 intervention components that we always use, and what does that look like for our SBIRT project? So, academic detailing. This is also sometimes referred to as peer consultation. And so this is when a primary care clinician is trained in the process and project content. So that would be a clinician being trained on all of the SBIRT, the evidence around SBIRT, the workflows for SBIRT, everything. So they can be experts in SBIRT and answer questions as they come up. And so what they do is we have a couple trained in SBIRT, and then they actually meet with the entire practice to kick off a study or a project to review and answer questions they have about the guidelines. And so we used to do these all in person. I will say that is one thing with COVID, we have really transitioned to a lot of these are being done over Zoom now, which really helps with transportation and getting across the state, some of these practices. So again, they review and discuss the evidence behind the proposed improvements. They discuss potential strategies that the practice may want to implement. And then they start kind of brainstorming a plan for tackling next steps. And usually in our projects, there's at least 1 or 2 academic detailer visits. It really depends on the project. And if a project or if an issue comes up in the practice, they can always request another academic detailing visit. I mentioned earlier, I gave the guidelines around opioid prescribing, and I showed there was like a 58-page document from the CDC and 198 pages from the VA. Well, so there are many of reports and documents and guidelines around SBIRT. And so another thing that we do is we create these academic detailing guides. So that is taking those hundreds of pages out there and distilling it down to a handful of pages to really highlight what do the providers need to know about this topic. And these are just 3 examples of AD guides that we use in our SBIRT OK project. So one is really talking specifically about tobacco, alcohol, and other drugs. The middle one really is targeting what is SBIRT and why. And then we also have another academic detailing guide that is specific to managing depression in patients in primary care. So why the benefits of academic detailing. So this is a place for the practice to ask all the questions they have about the topic. So everyone's on the same page and they understand what's going on about what the evidence and recommendations say. It's also a way to have a connection and feeling valued in the practice. We're providing a lot of education and resources. And that, like I said earlier, the academic detailer is available long-term if they ever need them. There are also challenges that we see with academic detailing and setting this up. So as you can imagine, there's a lot of work that goes into taking the hundreds of pages and how do we decide what we can fit on 3 to 4 pages and are we getting all the right information? There's a lot of work that goes into that process. And we actually work with some external partners on that who are experts in that area. And then another thing is what we've done is we've often used academic clinicians to be for the most part, to be our academic detailers for our projects. And it's really can be difficult sometimes to figure out how to compensate their time for that work, especially if you're taking time away from them being in the clinic where they're generating money and saying, can we use you and train you up to be an academic detailer? And so there are some financial and logistical things that have been challenging to figure out. And then obviously travel and complex schedules. So we usually have an academic detailer at least out of the Tulsa area and one out of Oklahoma City, because that usually helps with travel. But again, you're taking time away from their clinic time if they have to go drive to the Panhandle to deliver an academic detailing visit. But Zoom has really helped with that, and it's been really successful. We've also found, and we're going to talk a little, given how chaotic primary care can be right now, especially during pandemic times, right? We'll talk a little bit about that. We also have added an option where we know if some of the practice staff cannot be in an academic detailing visit, that we'll record it and they can watch it later. It's hard because then they don't have that option of asking questions, but it's better than nothing. Okay, and then another one of our core interventions is practice facilitation. So this really is elbow to elbow support. We have a small army of amazing practice facilitators that are located truly across the state. They're geographically in the areas that they serve, which really helps with logistics and travel time. They often are master's level trained or higher. They really are, I say they're like much more than research assistants, right? But if you think about it, they're doing everything a research assistant does, plus helping with practice redesign and quality improvement in the field. So that's definitely a special skill that they have. They're trained in formal QI methods. We also have one practice facilitator that serves as a lead for each of our projects. So they're sort of a point person. And they're responsible for documenting, all of their encounters. That helps us understand what dose and frequency of our intervention that we're providing. One of the first things that they do with a practice, so we have our academic detailer visit to kick off a project, to make sure everybody's on the same page about the evidence and the guidelines. And then one of the first things that they do is then they do what we call our practice assessment, and these are tailored to each of our projects. And so they sit down with everybody in the practice and they talk about what protocols do you currently have in place in your practice. And so each of these items is scored as everything from no protocol and or not used, all the way to protocol used all the time. And this really helps prioritize what a practice is going to work on. Because if they've already got something in place, we don't need to spend a lot of time there, right? And that is something that's worth pointing out, is that we've really developed all of these projects to be really flexible. You've got to meet the practice where they're at. Our goal for most of our projects are 2 practice facilitator visits per month. So usually they're going every other week. Sometimes we do an intensive period at the beginning of a study where they're going every single week for so many months to kind of get something in place, and then they may go every other week. It really is project specific. And again, if the practice needs something and needs help with something, then the practice facilitator is going out there to help with that. Again, we have been able to pivot many of these to virtual also, which has been really nice. And this is, in the practice, helping with practice facilitation is where the practice facilitators are spending a majority of their time. This is just to highlight one of the reports we have. I mentioned that the practice facilitators have to enter every one of their encounters into a database that we've created. This is an example of one of the reports we run off of that to understand how are we spending our time, what sort of interventions are we doing. And so just to highlight here on our SBIRT project, you can see to date, we've had almost 1,700 practice facilitator visits. That's huge, right? But you can see we're calling these practices. Sometimes it's, to set things up. Faxing is not commonly used, but surprisingly, we have a couple practices that are like, please fax me. So we will. Email, visiting them. We also have added web-based, because again, some of this is done over Zoom. Another big core intervention component is technology support. And so we actually, for SBIRT, we are partnering very closely with OFMQ. We help these practices with all things EHR related. As you can imagine, when you're implementing a new workflow, oftentimes you need to make modifications to your EHR to sort of support that new workflow. Again, we do not select our practices based on EHR, so we are working with all the EHRs. At this point, I know we have worked with well over 30 different EHRs across the state, and they can look very different. Some can be more challenging than others. But we also really assist these practices with data extraction, and again, those workflow issues, and how do you get your EHR to sort of work with you on supporting what you're trying to implement. In general, we try to do 1 or 2 visits per practice related to technology support, but for SBIRT, there's actually quite a bit more, because one of the things we really wanted to implement was performance measures with SBIRT, and so that we could monitor how this, where we are sort of in implementation, and are these steps happening. And interestingly, there are not a lot of endorsed performance measures related to SBIRT. So for example, and again, this is really probably hard to see up here, but there isn't a endorsed performance measure to track SBIRT screening rates, right? And so we worked really closely with OFMQ, and we've developed what we think is a really good performance measure to monitor this. At the same time, there are endorsed measures tracking tobacco use. So for example, it's sometimes we can use an endorsed measure to kind of track this if that's already available through the EHR. And this has really highlighted a lot of the functionality that can and cannot, is often not in some different EHR systems, and the variability across EHR systems, right? Some can create a measure, some cannot. And so if it cannot, then sometimes we're stuck with, let's do chart abstraction, let's manually look in the EMR, and that's a lot of work. But again, we really think these performance measures are really important. We believe heavily in performance feedback. We believe strongly that it's really hard to improve on something if you aren't measuring how you're doing, right? And so we believe, we have to get this data back to practice quickly. And so we've created this process where we will get data out however we possibly can, right? Like I said, if that requires chart abstraction, we're doing chart abstraction. We also provide a number of dashboards based on all of the data we're collecting. So these are just a few examples of different dashboards. We take a lot of the surveys that they're completing, which I'll show you in a minute, and we'll roll them up to a practice level so nothing's, individually identifiable, and give them, how are you doing? Maybe how are you doing compared to all of the other practices in this study? This one right here, we look at burnout. How are all of the providers in your practice? How are they scoring on their burnout scale? Things like that. I mentioned we're collecting a lot of data. That's probably an understatement. I mentioned we're collecting information on every single encounter we do with a practice. So that allows us to really look at what sort of intervention dose, frequency, and duration does it take to implement, to see change in a practice or see their SBIRT screening increase, for example. We also collect a lot of information about the practice, understanding demographics and practice characteristics. Are they rural? Are they associated with a much larger health system? How big are they? Do they have an embedded behavioral health person? That's, could be a very different workflow if they have that. And then we ask every single person. So every single person in the practice is consented to participate in our projects. And every single person completes surveys. That gives us some great information about who works in this practice. We also, at very beginning, we kind of gauge their understanding of the evidence-based guidelines, because then that helps us understand how much training and education we need to do to kick off the project. And all of these, we, and by we I mean Carol Kuplicki, has built into REDCap very beautifully. And we've also built, with the BI team in medical informatics, we've created a pretty fancy process for pulling this data out regularly. We're all, we have practice facilitators across the state in the field, in these practices every single day. And so it's really important we have all this data coming into REDCap. How are we getting that back to the practice facilitators to then provide to the practices? And so everything gets entered into REDCap. We've built an API to where we are sucking the data out of REDCap automatically. I think we're at every 3 hours at this point that we're refreshing, which is really impressive. That goes into a SQL server. We're using Pentaho, and then that we are then providing SSRS dashboards that is are web-based, so that again, those practice facilitators can get out in the field. And this is just a screenshot of our SSRS. We have lots of folders, lots of reports and dashboards that they can use. Let's see. And also a lot of that data cleaning that goes into cleaning the data before the dashboards allows us to have some really clean data for evaluation also. Checking my time because we could talk about this all day, but we also have several other things we're doing related to SBIRT. We do have a CME program, and it's actually undergoing some significant updates right now, and will be those updates are going to be available like in January, so that's exciting. We also have the RPR Exchange. This is an online place for providers to subscribe, and it gives them an area to sort of talk to each other about different issues. And so they can really talk about relevant or, start a chat and how are you dealing with this, or what are you seeing related to this or that, right? So in our last 20 minutes, and then hopefully we'll have room for questions, I just wanted to highlight, and that was very quick, right? But we are doing all of this work, working with these practices to implement SBIRT. Again, that sounds really easy. I hope you kind of see it's really complex and there are a lot of steps that need to be implemented there. This is not without challenges. So some of the things that we are seeing out in the field is obviously the pandemic over the last few years has really impacted what primary care looks like, right? And the effects are still seen. We are seeing astronomical rates of staff shortages and turnover. And this is having a significant impact on implementing SBIRT because you train the front desk person to hand out the tablet, and the next week, the front desk person no longer works there, right? And then you get a new person and we're like, okay, when can we train you? When can we do this? And they're like, I'm trying to figure out what is going on here, right? And so it's constantly trying to meet them and figure out when we can get them trained. While staff turnover is just, you guys have probably, many of you have seen this, right? And or leadership is changing. We've also had practices over the last couple of years closing their doors, being bought out by larger healthcare systems. And then it's sort of, you got to start all over and say, okay, does the new leadership agree that we're still implementing SBIRT, right? There's just a lot of challenges there. And then also difficulty prioritizing QI or quality improvement or adding a new thing. A lot of that has to do with, I mentioned burnout is really high among providers. Staff turnover is really high. So it's really hard to be like, now I need how am I going to add this one more thing? Right? We're hearing a lot of providers talk about how, many of their patients haven't been in a couple of years. They're really far behind on just general screenings. And it's like, we need to focus on, our breast cancer screening, colon cancer screening. How are we going to focus on this? Right? It's like one more thing and everybody's stressed. Does that make, I see heads nodding, so I think you understand and you're like, that makes sense. I see it. We've also found buy-in at all levels is so important, and we've seen it both ways. We've seen it where, the highest levels of leadership are like, we are implementing this. This is the right thing to do. Our patients need it. But then you have the front desk staff who's like, I don't have time for this. And they just don't do it, even though leadership is saying we're doing this, right? Or vice versa. But if we've seen, it's like, but if you don't have the highest levels of buy-in, then it's really difficult to implement something like this into primary care. Lack of EHR integration. This has been a constant pain point for many of the practices. We are really excited we have this external screening tool because many of the EHRs do not have that functionality. Right? They do not have, they may have a functionality to screen maybe PHQ-9, tobacco, but maybe they don't have the audit or the DAS-10. They don't have all of that functionality, right? And so having a comprehensive screening tool has been really helpful. However, the challenge is, like I said, what is that workflow or what's the process for getting data from the screening tool into the EHR? And then minimal reimbursement for SBIRT activities. This has been really interesting. We actually had for a year, I believe, hopefully I don't misspeak. For a year, we tried providing $5 reimbursement per screen to the practices. So we basically did our own bonus payment based on how many screens you're doing. We paid the and we built all of this in, to the budget and workflows and everything on our side. We tracked every quarter. If you did 10 screens in the quarter, you get $50, right? We paid them quarterly. Interestingly, we were really hoping, right, the hypothesis there, which is this is part of the research, right? We tested this out. We really were hoping we're going to pay them for this activity and we're just going to see screening rates skyrocket. And that did not help or happen necessarily. We had a couple that took advantage of it, right? But not everybody. So that tells us it's more complex than that. And we've got to figure out what those pain points are, right? Several, with the Department of Mental Health and us, we actually met with the Healthcare Authority a while back and talked about, though, I know they are working on adding reimbursement for SBIRT screening moving forward, including positive and negative screens, I believe. And so hopefully that will help when it's more universal. That's the other thing is we do help these practices with how to reimburse for the activities they're doing. And as you can imagine, it differs based on Medicaid patients, Medicare patients, different, Blue Cross Blue Shield, community care, like they're all different. And so we also work with partners to bring in, to do the research on how to help make sure that they're maximizing reimbursement for these activities. And then, like I said, performance measures do not exist. So we sort of created some of our own. We think that's a great area for improvement. And because it would be nice if across the country, we were all measuring this the same so we can kind of compare and contrast how we're all doing if we're all measuring it the same way. So what have we learned? This is my uphill battle on a rocky something, I don't know. But we have learned primary care really does need the extra help, right? They need D&I support and not just for SBIRT, right? We've seen this across all of our projects. We've helped with COVID protocols and COVID testing. They needed the help, right? We've helped with cardiovascular care. We've helped with opioid prescribing. They definitely need this help. It is a little challenging in that the way that we're able to provide that right now is very topic specific based on what funding is available. And so that sometimes can be challenging. And then we've learned, flexibility is key. Like we know what we want these practices to accomplish, but obviously we have to meet the practices where they're at to get them there. We've had some practices, it's sort of like if we can't help solve their staffing challenges, it's, you're never going to get them to start screening, right? And I showed you all that practice assessment, and that's really helpful too. Like we don't need to spend time on things you all already have implemented. Let's focus on things that you don't have implemented that you should. And then having that technical expertise really is helpful, like understanding how we can maximize EHR functionality, knowing that every practice has a different EHR and therefore functionality. Two practices could have the same EHR, but they have different versions of the EHR and therefore it's completely different functionality. Moving forward, something we're really heavily researching and hoping to take advantage of is we are seeing there are a couple of the big EHR players that have almost all of the SBIRT screening sort of protocols or, in place. And so we may do some more targeted recruitment of practices that already have some of this in their EHR, because I think we'll learn the differences or kind of learn if we take away the barrier of a screening tool in a separate system and we work with the screening tool in your EMR, now what challenges do we have? And I think there's a lot of lessons to be learned there. So that is everything I have. I want to acknowledge again, there is a giant team behind this. I work really closely with Steve Crawford, Chuck Tryon, Tim Van Wagner on all of this. Cheryl Critchley is our PF lead on our SBIRT projects. I mentioned we have an army of amazing practice facilitators and the Department of Mental Health for funding this work.